It's something I haven't done before, but I thought I should do, just so that you people know that who the people are of the Prostate Forum. Give you a little history of myself. I was diagnosed 17 years ago, and presently I have stage 4 metastatic cancer to the bone. And yet, I've never had a symptom. I had a PSA yesterday, and it's 0.015. And the only reason it's that is because that's the lowest that the machinery goes. The only reason I say that is I'm standing here with metastatic stage 4 disease. And I just want to let everybody out there know that no matter where you are, there's hope. I'm living a very fulfilling life after having prostate cancer for 17 years. And I haven't slowed down a bit, even though it's stage 4. So those of you that aren't stage 4 and metastatic, you got a long way to go. Okay, before we get started, I'd like to make a few announcements. First of all, there's something a little unusual that I want to mention that Murray, is Murray here? He's not here yet. He's our founder. He brought to my attention, do any of you out there get emails from Dr. Stephen Strong? Okay. Then I will, only one, but one's worthwhile. His email was hacked. And you will get a fake email that says, please view the document I uploaded for you using Google Docs, and it says, click here. Don't do it, because it leads you down the road to all kinds of bad things. So he has been notified, he will correct it, but in the meantime, any of you that get emails from Dr. Strong, don't open this email. On to some other announcements that I have to have. It's nice to see we have more than the normal amount of ladies in the audience tonight, and I will address a few things for you ladies, but most important, I want to talk about prostate problem people have to know where the restrooms are. And that also includes you ladies, even though you don't have prostate problems. If you go out the door, you come in and turn to your right, that's where the ladies in the men's rooms are. When you come to these forums, you share information with each other and you learn from them. Another way to learn is to get even more involved, and the Prostate Forum of Orange County is looking for short-term help on projects such as investigating grants, prospective public advertising avenues, and anything else that your background knowledge would contribute to the Prostate Forum. We're looking for assistance because so many times we have people in the board say, hey, here's a good idea, we ought to do it. And then we think, okay, well, he's got this to do, and he's got this to do, and he's got this to do, and he's got this to do. Who's going to do it? So we do need help, but the advantage to you is you get to learn more and more and more about prostate cancer. You get to learn more than you do at these forums when you're involved. So I submit to you that we're looking for help, but it's going to be rewarding to you in return. Also, prostate cancer is a family issue. And if there are any women out there that would like to contribute by helping us further our cause, please see me or any of the board members, and I will have the board members stand up later on, because we welcome your help. The reason I say that is breast cancer is 4 times more successful at doing what they do than prostate cancer people are. The men of prostate cancer are not real willing to go out and talk about their disease and having it checked and having it tested and fundraising, etc. But the women are all out. So we would like to welcome the women with open arms to help us out on some of these things. And because, as I said before, prostate cancer is a family disease. We do have to support our expenses, and if you can help, we would appreciate it. We get about half of our expense monies from your generous donations, and the other half from the rest of the community. I'll have a couple of board members pass the basket. I got my baskets right over here. just like you were in church. So, thank you, Larry. Thank you, Webb. At this time, besides Larry and Webb, I'd like to have the prostate board members stand up so that you can see who they are and who you can talk to. Charles, that means you too. Stand up. Oh, you put your money in first. Put your money in first, then stand up. There you go. Okay, I don't see any other board members here that aren't standing. Unfortunately, we've had some illnesses in our board members tonight. And oh, John Agrusa, you didn't stand up. And okay, so we have about 5 or 6 board members in here in attendance tonight, and we have several that had health problems that couldn't make it tonight. So there's generally about 14 members attend our board at each meeting. These are the men that give selflessly without compensation of their time to provide you the help and support that you need. These are also the men that you can talk to about the prostate forum or about prostate cancer problems or the assistance that I ask about. If anybody here would like to assist with our work and learn more about prostate cancer, please see me or any of the board members that you saw stand up. Tonight I will have the pleasure of introducing Dr. Stephen Williams. But before I do, I'd like to make a few comments. We'd like you to hold your questions until after the presentation is done. And then Dr. Williams will be available for questions. And Dr. Williams, I'd like to ask you to do something for our benefit. Normally, you get tied up right here because people want to grab you right away. If you could at least step a few feet beyond our table back there, because we need to tear down and we hate to get your foot trapped in the wires and hurt somebody. So step back beyond the table after we're done. I'd appreciate it. Before I get into the formal introduction, I'd like to introduce somebody just as important in our fight against prostate cancer, and that's Miss Enza Wynn right here. She's a nurse practitioner, but she's more than a board nurse practitioner. She's board certified nurse practitioner. Stand up and turn around and take a bow, Enza. And the reason she's here is she assists Dr. Williams at the hospital. So anybody that pretty, you know you've got to be in good hands right there. There's incentive just to go to that hospital right there. Okay. Dr. Williams is a Harvard-trained urologist and surgeon. His clinical interests lie largely in robotic and minimally invasive surgical treatments of urological cancers, including prostate cancer, kidney cancer, bladder cancer, etc., and enlarged prostate, or as we know it as BPH. He has specifically helped pioneer robotic surgery at Harvard in the treatment of prostate, renal, urethral, and testicular cancers. He has over 50 peer-reviewed publications, 4 book chapters, and over 25 presentations at local and national meetings. Dr. Williams has extensive experience in robotic da Vinci laparoscopic prostatectomy. All 4 of those words tied together make a mouthful. Including cryotherapy of the prostate and the kidney, with several publications in each area. His studies have demonstrated an excellent chance for cancer cure with, listen to this guys, with no change in penile length. Not very many treatments that can claim to do that. With decreased pain and with excellent functional outcomes in men undergoing robotic prostatectomy. Ladies, Dr. Williams is also very experienced with female urology, including stress, urinary incontinence, female pelvic prolapse repair, and elevate procedures. Female sling procedures, including the Monarch procedure. and men with prosthetic urology, including male sling, artificial urinary sphincter for male incontinence, and penile prosthesis for impotence. Excuse me while I get this page unstuck from the other page. Dr. Williams speaks both English and Spanish. Dr. Williams tonight will present current status and information on cryotherapy, which uses extreme cold, inert gases as therapeutic agents for prostate cancer treatment. The cold gas is used to destroy the tumor cells on contact. He will offer a brief history of cryotherapy from its rudimentary beginnings to the present high-tech capabilities. He will discuss the criteria for qualifying patients and who could benefit from these techniques. And just as importantly, the outcomes which can be expected. He will explain the process details of both focal, and focal is a big thing these days, and total treatments, and provide a look at the new ideas or tools soon to be available. Prostate Forum of Orange County is pleased to present tonight Dr. Stephen Williams.
So thank you for having me this evening, and more importantly as well, thank you Marty, Dr. Wiseman, for specifically inviting me. Dr. Terzakian actually is my mentor here now, specifically with cryoablation of the prostate. Unfortunately, he's unable to make it this evening tonight, but on an international scale, we're expanding our services abroad. So he's seeking to establish those opportunities as well. So tonight I'm going to talk specifically about targeted cryoablation of the prostate and how that pertains to the treatment of prostate cancer. Prostate cancer treatment, as many of you are very well versed, for curative localized disease, different treatment options do exist. The first of which is surgical therapy, which is radical prostatectomy, and I've been trained specifically with the open and robotic approaches, and are obviously very viable approaches, however come with corresponding morbidities and complications from the procedures, which we'll discuss when we're comparing the various treatment options. Radiation therapy or radiotherapy, many of which in this room have had external beam radiation, which consists of either 3D radiotherapy, which has been administered in the past, as well as also to IMRT and brachytherapy or combination thereof. Cryoablation of the prostate, also to include in radiation therapy, I think we could throw in proton beam therapy, which many of you also have some knowledge and experience about that as well. Cryoablation or cryosurgery, cryotherapy, or cryo are some of the common acronyms that people have used to describe and publish in regards to cryoablation. Non-curative options for advanced or metastatic disease obviously include, as a possibility, active surveillance, which could also be bumped up to curative for localized disease as an option. But also to hormonal ablation, which can include a chemical or surgical. So what is cryoablation? And this has been previously alluded to, but I'll go into obviously more detail. The first of which is a minimally invasive percutaneous procedure with the use of probes that are inserted through the skin into the prostate gland itself. The cryo destroys cancer cells by exposing these tissues to lethal cold temperatures. And we utilize this specifically for prostate and kidney cancers. It's an outpatient procedure, before of which, and this slide needed to be updated. It used to be an overnight stay, and now we've converted all of our procedures to an outpatient procedure with return to normal activity roughly in about 2 weeks. I would even lessen that to about a week for my patients. This is a Medicare approved procedure and a covered procedure since 1999. However, despite this, it's still a seldom used treatment modality for prostate cancer in the community as well as in the academic arena, and I'll allude to that further in the presentation, compared to surgery and or radiation treatment, as few urologists and or radiologists are trained in utilizing this and providing this as a treatment option for patients. So the evolution of cryoablation, hopefully you guys don't fall asleep during this, is prostate cryo was first tried in the early 1960s using a transurethral approach monitored with digital rectal exam only. The technique was abandoned until the early 1990s because of the significant side effects. As you can imagine, without the use of any particular radiographic imaging, such as ultrasonography, definitely MRI wasn't present back then, led to significant side effects. And cryo was reintroduced in the early 1990s because of significant technological as well as procedural advances, which include but are not limited to the use of ultrasonography, vacuum-insulated cryoprobes, temperature probes to preserve the vital structures that are present in and around the prostate gland itself, and intraoperative treatment planning, which I think is a vital component to the treatment success for cryoablation, as well as a urethral warming catheter, which prevents urethral damage. So prostate cryo was tried in the early 1960s using a transurethral approach monitored with the digital rectal exam. It was abandoned from the side effects, and then the urethral warming catheter and all these other additional modalities, with the number of prostate cancer cases treated by cryo has been increasing annually, specifically fourfold from 2004 to 2005. And I actually analyzed, did a data to derive that information comparing cryotherapy versus brachytherapy, which noted a significant increase. And I would think that this is even increasing even further now that particularly patients are interested in more focal therapies. So the indications for cryoablation, specifically in a patient who has primary stage T1 to T3 prostate cancer, does not want surgery or radiation treatment, is high risk for surgery or radiation due to significant comorbid disease, high-grade disease or locally advanced, and is concerned about urinary incontinence. I'll describe our outcome data and how that is important, obviously, when deciding a treatment modality, and is not concerned about post-operative erectile dysfunction. That's an important concept when considering on a treatment. Specifically with cryoablation, I always counsel my patients, as with any treatment for prostate cancer, but specifically cryoablation, this is a significant side effect of this treatment. And wants a procedure that can possibly be repeated at a later time, and wants a minimally invasive procedure with a quick recovery. Also too, as an option, and a lot of the data has suggested, is the utility of cryoablation as a salvage procedure. That means a procedure after a failed other modality, the most common of which is a failed radiation therapy, where cryoablation is of use. So the biology of cryoablation, during the freezing, anti-neoplastic effects, that means anti-cancer effects, result from direct cell death via extracellular and intracellular ice crystal formation that occurs within the cell and as well as the surrounding environment. Intracellular dehydration and pH changes, ischemic necrosis via vascular injury. The prostate gland is significantly vascular, and not as alone from the cell death, but destroying the neovasculature aids in oncologic efficacy. As well as the activation has been hypothesized of an anti-tumor immune responses. As these cells die and release the components within them, it's thought to believe that the body can then develop an anti-tumor immune response to destroy what other possible cellular components are present. An induction of apoptosis, which is cell death itself. Endothelial cells damage, which lead to platelet aggregation and microthrombosis, which essentially destroys the neovasculature. This is a graphical illustration which depicts from the left to the right the freezing cycle itself, leading to those architectural-like changes. But similar to, this is a surgery, and I think a key concept to realize is that as with surgery, when you're removing the prostate gland, cryotherapy as well kills the cells right then and there. With radiotherapy, there is a time lag between actual cell death. The cell needs to try to divide and then subsequently dies. So patients get an immediate treatment right then and there, and therefore I treat my patients very similar to my robotic prostatectomy or open prostatectomy patients when I do their follow-up. Additional injury is caused during the thawing cycle, and that's something I'll go into detail. There's 2 freeze-thaw cycles, which leads to cellular swelling and vasculature hyperpermeability. And what that means is basically you're just destroying and evicting those cancer cells and killing them at the same time. And a minimal freezing temperature of negative 40 degrees Celsius for 3 minutes is necessary to for efficient tumor eradication. The technique is guided by ultrasonography of the prostate. And I think this is a key component as well because it is operator dependent, and in doing so the surgeon is in control of the ultrasound probe. I have a video as well which can put this into better context. And then the temperature probes as well as the cryoprobes are determined by a computerized treatment planning, and this is quite revolutionary, particularly with the development and acquiring additional technology, which actually a newer system is going to be developed as well in the very near future to even add the possibility of MRI fusion. Activation of cryoprobes with ice fall formation under close and real-time ultrasonic monitoring is critical, and I think having control once again of the freezing cycle as well as the thawing, having computerized assistance combined with ultrasonography really aids, I think, in the goal of the treatment, which is to create a lethal ice fall within the confines of the prostate without damaging adjacent structures. Critical structures include the sphincter, rectum, and urethra, as well as, and I'll talk about briefly, the placement of the probes to preserve the neurovascular bundles. So the tools for cryoablation, this is the basic setup here, where we have the ultrasound, the probes here, you have the cryoprobes as well as the temperature probes. That's the monitor for the treatment planning. And the good thing, this is one unit, which allows for easy mobility. Being an outpatient procedure, I perform this both at the hospital at St. Joseph in the pavilion, as well as at a surgical center as well. Depends on the patient's preference. And in addition, the cryoprobes allow for an insulated 2.4 millimeter vacuum insulated cryoprobe within an elliptical ice ball is essentially the goal here. This is a pre-procedure ultrasound. I'm sure you may have seen many of ultrasounds here. And that's the prostate, obviously, right in the center. That's the ultrasound probe in the rectum. And going over the treatment plans, so placement of the white as well as the temperature probes, which are blue, which are faints down here, such as the neurovascular bundle. We're able to essentially every patient's unique in their prostate gland anatomy and essentially tailor the appropriate placement of these probes to allow for the best treatment. These are the cryoprobes that are placed. You can imagine these areas here represent the individual probes. Right here is the urethra itself. And it really does take, I think years of experience. I'm very fortunate in my training. I think one of the things, my chairman said before you leave here, Steve, you're going to be, a uropathologist, a uroradiologist, and then you'll leave it, as a urologist or urologic oncologist. And I think all those years of putting time in have really aided me, I think, in, having the success that I've had. So with the targeted cryoablation of the prostate. This is obviously a more graphical illustration. The probes are inserted through the perineum under ultrasound guidance. And as you can see here from the right to the left, there's a lot that can obviously be injured if one is not savvy either with their anatomy or, more importantly, the use of this modality of treatment. As many of you may know or understand, it's the similar use of robotics. It's a tool, it's an instrument, but the person who's behind it, I think also too, is a very critical component to all of these wonderful treatments that we're able to offer now. And that comes into play especially, and we'll go down when we're actually placing the probes itself. The lethal ice ball is formed, and another important component to realize as well, this is under real time, so when the ice ball is formed, I'm seeing this form and paying particular attention so that this ice ball doesn't just simply expand and damage other adjacent structures, which are protected by different sensor probes. However, more importantly, I think, is the direct visualization. Let me see if I can press, there's a little video button. So this is a real-time kind of illustration of the probes that are going to be placed. There's the rectal ultrasound, which is introduced, and here are the various probes which are placed in the prostate gland itself. The neurovascular bundles, you can see below, and then the urethra right in the center. And those are the temperature probes. Once placed in the layers, Denambiers fascia between the rectum and the prostate to protect it, and the neurovascular bundles are protected, the sphincter as well. That's the first ice ball formation, and then that's the passive thaw cycle itself. There's another second ice ball formation. Obviously, we're giving this not in the real time. You allow everything to do active and passive corresponding. And then that's the second thaw cycle. Essentially, this is supposed to represent cell death. And then that's the procedure itself. So with the, before the cryoablation of the prostate, we have right here is the native picture without the probes placed, and that's the other one with the probes placed. After the procedure, and you can kind of see this prostate here. And essentially what's happening as you're trying to look for, and this is not as better characterized on this computer screen, but you can see a bit of tissue right here, the adjacent fat structures, which are preserved, and essentially destroying the prostate cancer itself. During this time as well, also more importantly, or one of the important factors is we're protecting the urethra with the insertion of a urethral warming catheter, thereby protecting the urethra as well as the periurethral tissue. So the clinical outcomes, I think I'm a big nerd about this stuff, and before I was going to implement or decide to implement cryoablation as a treatment in my armamentarium, I wanted to make certain that this is in fact a valid treatment option. And the good thing is there is some data that's out there. However, as with any new treatments that are offered, there needs a particular lag time for outcomes to develop, and I actually entered at a pretty good time. At 2003, there's a team over at Columbia with Dr. Katz who reviewed the current and potential role of cryoablation as a primary treatment modality for localized prostate cancer. He did a comparative analysis based on all studies of primary cancer therapies reporting rates of a 5-year biochemical disease-free survival. And all studies were published as papers in peer-reviewed literature over a period of 10 years. And this analysis stratified the study results by risk groups, low, moderate, and high-risk groups. And to look for trends, not designed for a conclusive comparison of the different treatment therapies, but provided somewhat of a good overview of how cryoablation compares to this. Low risk was defined in this study as stage 1 or T2A, Gleason score of 6 or less, and a PSA of less than 10. Moderate or intermediate risk was defined as greater than PT2A, a Gleason score of greater than 6, and PSA of 7, or PSA greater than 10. Sorry, the Gleason score of 6 is actually a Gleason 7. And then for high risk, greater than PT2A, Gleason score greater than 7 or 8 to 10, PSA of greater than 10. And in looking at these varying risk stratification, particularly with the low risk, as you can see from moving around prostatectomy to external beam, cryotherapy seemed to average quite well, and that's the distribution, the range for the biochemical disease-free survival in low-risk patients. Low risk, I'm not as concerned about much anymore because most of these patients, as we all know, should be initially on an active surveillance protocol, at least in my office, how I counsel patients. But more importantly are the intermediate, or as he defined it, moderate risk groups, as well as high risk. As you can see here in the moderate risk, 89 to 61% actually fared quite well in regards for the different varying treatment modalities. Granted, this was some years back, so other radiation oncologists would say you don't have particularly the IMRT or combination treatments, and where's all proton therapy, and the list goes on. But still provides a pretty good treatment modality. It's also as well, and although a recent paper, and I talked about over dinner this evening, with the high-risk group, actually fared well, 89 to 36% for cryoablation. However, there's a recent paper with not real significant numbers in either group, but seem to suggest that radiotherapy seems to offer superior outcomes. So the authors also noted a lower positive biopsy rate with cryotherapy than observed with radiation therapy. And that's actually been proven, particularly in that randomized trial that seemed to favor radiation treatment over cryoablation. However, cryoablation had less positive biopsies, equivalent metastasis disease-free survival, and equivalent overall survival. In addition, the health quality of life scores for cryo are quite high because of significantly less or short and long-term morbidity compared to the other treatment modalities. There is significant erectile dysfunction, and that's something I always counsel my patients when they're considering this particularly treatment option, is whether or not erectile dysfunction is important in deciding what their treatments are. Also, too, I let them know that if they do have erectile dysfunction, that there are treatments to actually restore that in their lives afterwards. So the authors concluded that prostate cryoablation is expanding rapidly because it is safe and efficient, and it should be offered to patients as a treatment option when presenting with localized prostate cancer. This is a study. The table, is a little busy, but more importantly, looks at the morbidities of the different treatments. And just as a lump sum, looking at rectal injury, some of this data here is from the earlier cryoprobe system or cryoablation system, where it's 0 to 0.5% for a fistula, which can develop. However, as you look at incontinence, it's quite limited in 1 to 7%, and impotence, however, is quite significant. The literature evidence also indicates that cryoablation is safe and effective in patients with radiation therapy failures, and there's a large number of data to suggest this as a current effective and treatment modality, and is currently in the guidelines, the NCCN guidelines, for a treatment modality for radio-recurrent prostate cancer, if it's in fact localized. And cryoablation is effective in the treatment of a high-risk patient population, and I would even extend that obviously to the intermediate risk. And recent 10-year retrospective data on roughly 250 patients, so a biochemical disease-free survival of 77%, and a prostate cancer-specific survival of 98%. So in the summary from this information is that cryoablation is indicated for the treatment of all stages of primary prostate cancer, except for PT4 disease. Salvage cryoablation is safe and effective. And 7 to 10 year clinical outcomes data for cryo are comparable to other treatment modalities, and I'll talk specifically when we talk about our outcomes, where I'm working with a large registry to compare our outcomes at the national level. And cryo seems to be more effective in moderate and high-risk patients. It's a minimally invasive treatment with low morbidity, quick recovery, and favorable clinical outcomes make cryoablation a viable option for the treatment of both primary and radio-resistant prostate cancer. So what does this mean in regards to you guys here, and also to the benefit that we can possibly offer our patients who are diagnosed with localized prostate cancer? Well, the first, and I'm proud to say that with the help of Dr. Jazakian, of course, we are the most experienced cryotherapy program in Orange County. Over 200 patients have undergone cryoablation of the prostate, either as primary, salvage, or focal cryoablation. We are members of the Cryotherapy Online Data Registry, or COLD Registry, which enables us to compare our outcomes to those at the national level. And this registry, which is the COLD Registry, is the largest registry that has been developed specifically for cryoablation of the prostate. And I have, through the benefit of our experience, to actually be a part of this, this registry, and working very closely with urologists at the Cleveland Clinic, MD Anderson, and other centers conducting research and publications dedicated to the field. So, and it's not uncommon, you know, if I have a patient who I counsel, my patient could be rest assured, and quite often sometimes I in fact do, is talk to Dr. Jones, who's the chair at Cleveland Clinic, to see, you know, what his thoughts are about X, Y, and Z. But I think more importantly, and we'll talk about the research that I've conducted to compare and ensure our patients that we're providing them the utmost benefit. There's a current study which I submitted for publication with Johns Hopkins and Brigham and Women's Hospital and Harvard Medical School, analyzing our oncologic outcomes, cancer outcomes, following primary cryoablation for the treatment of prostate cancer according to risk stratification. And 95 consecutively treated patients with complete medical records and no loss to follow-up who underwent primary prostate cryoablation were candidates for inclusion of this study. None of these patients had hormonal ablation after treatment. Quite often before the treatment, due to the prostate gland itself, there are certain restrictions where you need to have hormonal therapy to help shrink the prostate gland. And that usually is about 1 to 2 months before treatment. I performed univariate, multivariate survival analyses to identify clinical factors which may be significantly associated with the likelihood of biochemical recurrence, using a definition of which many use in the radiation treatment field, which essentially is the PSA that it comes down to in a patient after treatment +2. And it's called the Phoenix criteria. The median patient age in our population was 71 years, with the PSA approximately 7.6, and the clinical stage being T1C, i.e. identified by PSA only in 61% of the population. We had a pretty good cohort across the board for low, intermediate, and high-risk disease. And after a median follow-up of a little over 2 years for the entire cohort, we looked at patients from 2005 to present, at 26.6 months, the biochemical disease-free survival rate for low, intermediate, and high-risk disease were 88.5, 83.8, and 77.8, which fared very well with the current published literature. Looking at different analyses, and basically it's a very complicated picture, but looking at factors that have been identified previously in other modalities of treatment to discern who's at a greater risk for recurring from prostate cancer. Down here, which is obviously cut off. The PSA nadir was the only significant predictor for patients who do or do not recur after prostate cancer. So our current study is on top, and this slide compares our study and our findings, which is very important, to previously published literature as well as different treatment modalities. Many of you have heard about high-intensity focused ultrasound, or HIFU, being performed maybe in the Caribbean or elsewhere. And more importantly in Europe, which has performed the greatest number of HIFU, brachytherapy, external beam radiotherapy, IMRT, and RP and RALP are radical prostatectomy, which is open prostatectomy, and robotic-assisted laparoscopic prostatectomy. And at varying follow-ups from our current study, what we end up finding is our low-risk disease actually fared quite well. But I'm really not focused or excited about that as much because I believe, as I mentioned before, patients now should be counseled accordingly considering active surveillance. However, it also depends, how many cores are positive, so on and so forth, and I won't get into detail with that. However, the more important, I think, are the intermediate and high-risk disease, which can fare quite well, particularly in these patients, although the median follow-up is 26.6 months in our data, as we know, at least from our experience, that these intermediate and high-risk disease patients tend to recur if they're going to recur sooner than later as compared to the lower-risk disease patients. And with the high-risk disease at 77.8, we perform superior to the other modalities. However, I must stress that the follow-up isn't as quite extensive, such as for surgical therapy. However, we're quite excited about these results and look forward to our publication. Morbidity, I think this is a very important concept whenever deciding any treatment. As we want to have cancer cure and don't affect my life. Let me go on and let me do everything that I was doing before. Our patients have no hospitalization. There were no patients that had any urinary incontinence. No patient required a pad after the surgery. I was quite surprised, as why I thought there would be at least one or two or a little bit more. However, no patient had urinary incontinence. There were no rectal or bowel complications. However, there is associated erectile dysfunction. A majority of our patients that we select for this treatment have preoperative erectile dysfunction. And there's a previously published data, about 50% of the population in itself, men without prostate cancer, have some form of erectile dysfunction. And there's 15-year data, at least from the prostatectomy and radiation literature, that tend to support up to 75% over the long term develop a form of erectile dysfunction. However, erectile dysfunction can be treated. So, but I do counsel my patients that they will have erectile dysfunction after the procedure. And they may experience irritative voiding symptoms. However, this resolves, after the procedure in about a month or so, particularly with or without the use of medical therapy. So, in conclusion, from our experience and from our study, we found a non-significant correlation between the higher risk prostate cancer and increased risk of biochemical recurrence, as you would expect. The increased risk of disease may increase the risk of disease recurrence. The nadir PSA, or how the PSA falls down, and as we looked at in our series, if it's greater than 0.6 after the procedure, the patients need to be followed very closely because they have an increased risk of needing additional therapies and or hormonal therapy. I've not had a patient that has been 0.6 in the nadir PSA, and I think a large part, unfortunately, has to do, fortunate or unfortunate, is just my increased awareness and knowing this information really at this time that I'm in doing my therapies. And nadir PSA, after we talked about that, and within the first 2 years, it seems to be important. Our constant and active involvement at the national, local and national level through clinical research and investigation reassures our patients that we provide the most up-to-date technologic advances which optimize cancer cure and minimize complications. And I think my patients, or our patients, really respect that, and I would as well. I came from a very high volume, well-known institution, and coming here, it's actually been beautiful because I've been able to not necessarily leave the East Coast, or at least from an academic perspective, and stay in close contact and develop new relationships and offer these to the patients that we treat. And that is it. Thank you very much.
If you can just hold on here just a minute, Dr. Williams, you're not off the hook yet. When I said that I would like you to step behind the table and take questions, what I was talking about was after the meeting adjourns, when there's some people that have some personal questions they'd like to address to you. Right now, however, I'd like to ask anybody that has any questions to come up here, and I'll give you the mic so that we can record your question and answers on the video that we're doing here. So if anybody has any questions, just come on over here. I'll hand you the mic. You can address your question directly to Dr. Williams. And while they're coming around, Dr. Williams, let me start it out with, could you talk a little bit about focal therapy versus whole therapy on cryotherapy? You know, it's a significant difference, and you can stay potent with focal therapy. Would you address that just a little bit about the difference there?
Certainly. The data is preliminary in regards to patients being treated with focal therapy. To be honest, the experience that has been had through the COLD registry, as well as other data that's been presented, there's different protocols for doing focal therapy, and these tend to be the patients that are in that low-risk category when looking at this patient population, i.e. a patient that may be a candidate for active surveillance, which wants some form of a local treatment. And I think before I counsel a patient on the option of a focal therapy, I really make certain that they are aware that they may in fact need additional treatments thereafter. Once again, this is a new kind of treatment modality that is being offered to patients, which fares quite well from a morbidity standpoint, particularly erectile dysfunction, of which half the gland with focal therapy treatments is i.e. treated with Temprobes, and or with the use of additional imaging modalities such as MRI, which I think, as I alluded to, and I can't fully disclose, but one of the cryotherapy companies is going to come out with an improved modality for identifying lesions or mother lesions of which to treat with cryotherapy probes. The preliminary data seems to suggest, with the caveat that patients have a series of at least 2 ultrasounds before the treatment with a primary urologist, and undergoing treatment to undergo a post-biopsy treatment within 6 to 12 months after the procedure, as there's increasing concern with the contralateral gland, and specifically from the data that we know, at least from the radical prostatectomy series, which also show that with the current techniques that we have with using PSA and other risk factors, including the biopsy schemes that we use, is that prostate cancer may be missed. So although focal therapy is an option for patients, and we have done this in our series as well, there's real careful counseling with the patients so that they really completely understand what they're buying into. And I essentially, and what the data seems to suggest as well, is that these patients who are carefully selected understand that they need to strictly adhere to essentially an active surveillance protocol.
I just have a couple of questions for you. Okay, can you hear me?
Yes.
Okay. How many of these procedures beyond the 200 that have been done locally have you done?
Have I done? I've done, I think, approximately 20-25 personally. Here in Boston, I've done approximately 25. And it was actually just introduced in Boston, and I actually had to go to another adjacent institution to actually perform the procedures.
Second question is, if you've been diagnosed and you have perineural invasion present from your biopsy pathology, so those little critters run down the channel, cancer critters, what does your ablation do for that?
Well, I think it's also the disease itself. it depends on the Gleason score, how it was on rectal exam.
On 8.
And 8 disease. To be honest, I would get other imaging modalities to be certain that you have organ-confined disease, i.e., usually the treatment or the staging modality would consist either of a CT scan or MRI, which I'm increasingly utilize, particularly if you have perineural invasion, because that's the path of least resistance. And for me, as well as my patient, bone scan as well, to really make certain that the disease is localized and that with the local treatment. And that brings a great point, actually, and thank you for bringing that up. With the data that we have at hand, with the radiation treatment versus cryoablation, and before I initiated this, my inclination was, well, if we're just treating the prostate gland itself, we're not treating the surrounding tissue, right? So we're not treating the lymph nodes, which obviously are a hot spot that we may miss. And the good thing with time and studies, in the recent study that did come out, there's no difference in metastatic disease-free survival, i.e. disease outside the prostate gland, with primary cryotherapy versus radiation treatment. But to answer your question, I would get additional imaging modalities and have a real intimate discussion with the patient, given the fact if it is localized disease, that I can't promise them that there may be micrometastatic disease outside the prostate gland.
Okay, the last question I have, escaped me at the moment. I'll come back to it.
Hi, my name is Caleb, and my first question is, you save the vascular bundle, you save the sphincter, you save the urethra. Can you explain why there is erectile dysfunction after this, what seems to be a perfect surgery?
Sure. So it goes back to the anatomy, of the prostate gland itself, and although it depicts in a lot of the pictures that the patients are presented, but not the surgical atlases, the neurovascular bundles sit very closely to the prostatic capsule itself. And although we insert the probes itself and maybe in that area, they become kind of like, imagine, anything that you stick with ice, it sticks to it, and the capsule itself is a pseudo-capsule, as Epstein Hopkins kind of points out. And with that being said, with those neurovascular bundles being in close proximity, it kind of brings them closer. And I think it really damages the architecture, if you will. They're kind of, like railways, so to speak, and you're taking out a couple bolts. And if you take out enough bolts, then it kind of disrupts things. So that's a great point. How come, you can't preserve? I don't do an oncologic sparing procedure also as well, where the cancer is located. I really pay attention to the area and really focus that. Because to me, my biggest concern is the cancer as well. Obviously the nerves and sexual function is important, but I'm not going to do a cancer sparing procedure. Conversely, I think that also tailors from my robotic prostatectomy experience, and at least how I've been trained. Don't spare the nerves and leave cancer behind. If you're able to spare nerves, then do so. And I apply that to my cryoablation techniques. And it seems to coincide, obviously, with the prior experience and the other data to suggest that.
My second question was, you're not my plan, so how do I find a good, what questions do I ask a potential doctor to make sure I'm getting the best cryo doctor, or a doctor with the best cryo knowledge like you have?
Terrific. No, that's a great question. And I think it comes down to first, is there anyone, do you offer cryoablation? And ask him or her if they offer that as a treatment modality. I think a key point as a patient, and I think this forum does a beautiful job, and it was a pleasure actually to have dinner, to understand why support groups are developed, because as a patient, you hear of cancer, oh my gosh, it's like, what's going to happen? I need to take it out. And I think unfortunately for a number of years, treatments were being overutilized, which have led to obviously an increased awareness of the complications, morbidity, and actually not favoring screening anymore from the primary care's perspective. But going to your question specifically, I would first ask, is that a treatment modality? Since you have knowledge right now, more so than probably as you walked in, ask if they don't, would you happen to know anyone that they may refer to? And if they don't, then you could always ask your plan. Like I mentioned before, and I know, at least in my time in Boston, we didn't really favor cryoablation a whole lot because, particularly my institution, maybe it comes from the fact coming from Harvard, everyone thinks they know everything, is that they didn't really respect it, initially as such. But due to my, curiosity, I sought to explore that further. And, I think even going beyond that, really looked at the data, visually myself before I offer to this, like any treatment, would you offer it to your brother, your father, and so on and so forth. And with your plan, if they don't, whether or not your plan would be willing to allow you to see someone else, outside your network. And I think over the next couple of years, a lot of things are going to change with regard for that. And I don't know where it's going to be going, but hopefully in the positive direction.
Hi, my name is Ken Hamilton. Dr. Williams, how you doing?
I've been trying to call you.
This whole thing is really daunting for me, and the questions might be silly for you. But on the cryo, how do you know if the cryo procedure is successful? What tests do you do, and how long after you do the procedure? How do we know that?
And that's a great question. And from the data that we have and that I've done, what we end up following, and I treat my patients much the same as my radical prostatectomy patients, surgery patients, following with a PSA level, which is a common follow-up as most of these modalities end up following. What I end up looking for, and what I really compare this to, is as I do for my surgical patients, I want that PSA to come down to less. I don't use the ultra-sensitive assay, particularly in the initial period. You may consider that later on, but let it come down to 0.1. That's my goal, or less than thereof. Then I follow up with a serial PSA every 3 months for the first 2 years, alternating also too as well with rectal exam, and then every 6 months up to year 5. I'm a little bit more aggressive, and maybe I think once again, maybe just my training, but also too, I'm primarily treating those patients that have intermediate and high-risk disease that need the treatments. And thereafter, I recommend an annual PSA.
So it's not just you get out of there and you're good. You don't know.
No. Well, like any treatment, you want to have particular follow-up to ensure the oncologic efficacy.
Okay, so it is sometime after you get the procedure. It's sometime
One-
years, maybe a couple of years
Before what?
before you know that you're good.
Well, it depends on the disease initially. The intermediate and high-risk disease tend to declare themselves sooner, and I say soon as in within the first 2 years, but you never know. Obviously, with the data that has right now, I would suggest even up to 5 years, and that's why, I kind of keep a closer follow-up for my patients.
Okay. Now this gets back to the other one that I was going to ask, because I see all these numbers and percentages and stuff up there. Almost falling off the chair. You're talking about low, intermediate, and high risk.
Correct.
The question is, what is the risk referring to? Is it the risk of dying? Is it the risk that various functions are going to go wrong, like the rectal dysfunction or the incontinence or something? Is it the risk of that going bad, or is it the disease? Is it the Gleason number? Is it a big number? Or the PSA is a big number? Is that the risk factor you're saying?
So,
is that why you say it's high, medium, and
well, it takes into more of it takes into the oncologic disease itself. And what do I mean by that? So Anthony D'Amico is my mentor, and he actually developed that risk stratification back at Harvard. And what he ended up doing was exactly your question, because a lot of the data that's out there, or patients that were out there, had varying risks of disease. And what does that mean? Different PSA levels, different rectal exam findings, and other findings as well, putting that into the stage, the PSA, as well as the biopsy schematics when you get your biopsy results back. And he looked at other factors as well, and ended up finding those 3 factors with different variables within those 3 different factors to be predictive of different varying risks of disease. And the risk of disease, when he was looking at that, was actually disease-specific survival as well as recurrence rates. And that's primarily when I talk about risks, it lumps patients into 3, what I think is the easiest way to look at it, as well as from a research perspective, so you can compare apples to apples, oranges to oranges, when you're talking to patients for various treatment options.
So it's the risk of how bad the prostate looks
Cancer.
at the beginning.
Correct.
It's not the risk of recovering or not recovering.
No,
or
it has nothing to do with
partially
recoveries. No.
So it's the risk of how bad that thing looks in the prostate, is that it?
You could say that.
I'm good with that. Well, no, I'm telling you, it's tough to...
It's complicated,
Yeah,
yes.
I'll tell you. Thank you.
I think it could be the risk of dying, right, from prostate cancer
Correct.
or reoccurrence.
I have the risk of dying.
I know, I got that. Yes, sir, we got somebody else?
Don't confuse them.
Phil has a question.
Larry, I'll ask him just a minute. Larry, go ahead.
I'd like to just kind of piggyback on what was said here. Usually when they report cures, many times they report it in 2 ways. One is biological or chemical failure, okay, or survival. Okay. Maybe that's not the technical words. You could enhance it probably. But when they give statistics, they do it in those 2 ways. So if it's chemical, it's usually associated with PSA. Okay. Does the PSA come back? Does it start rising at a certain velocity? Whereas survival, the individual die. So when they provide statistics, they usually do it maybe 2.5 years, 5 years, 10 years. Ideally, 10 years is in my opinion, the superior way to look at therapies. What is the data over 10 years? Thank you. There it is, biological reoccurrence.
10 years below risk.
Yeah, we're missing apples and oranges there.
Well, here we go.
Yeah. So what I'm saying is, there's 2 ways of measuring success and failure. One way is biological reoccurrence, which generally reflects PSA. Is the PSA rising in 10 years or 5 years? Or is it going down? Is it staying stable? You understand what I'm saying?
But that's a measurement of the recovery. That's not a measurement of what your risk is when you see it at the beginning. That's a different thing.
Yeah. There's a risk of intermediate, advanced, or what's the term? What is it? Low risk. Low risk, medium, and advanced. Low risk is generally when your PSA is below 10, your Gleason score is below, or 6 or below.
Yeah, let me just, excuse me, Dr. Williams, I'm going to pretend like I'm answering what you should be answering here. The risk factors are what the factors that the doctor takes into account as to determine whether you're going to have biochemical recurrence or not, or whether you're going to die. Low risk, you're not going to have much of a chance of doing anything. Intermediate risk, you have an intermediate risk of biochemical recurrence at which you'd have to treat or later on maybe die. And high risk is you have a high risk of biochemical recurrence, biological reoccurrence after the treatment. They diagnose the 3 categories to figure out the time that something's going to happen. Sorry, doctor, that's your area of expertise.
No, that was great.
Murray, you have a question? May I present Murray, the founder of the Prostate Forum of Orange County.
Dr. Williams, my question relates to this kind of a comment you've just been getting. I'd be interested in your impression and comparison of freedom from biochemical recurrence, biological recurrence, compared to brachytherapy for, say, low and intermediate. I see great data for the brachy, not so good for external beam, not as good for surgery. Where in your opinion will the cryo fit in that?
Well, I think that's an excellent point. One of the things in which is this confusing table. Looking at cryotherapy here, I tried to find the best study that I could see that really divided patients into varying risk categories. You're absolutely correct. There's a lot of wonderful brachytherapy literature that's out there with longer-term follow-ups. Particularly the one that I ended up finding was back from 2002 after having some years of experience. There ended up having, for intermediate and high-risk disease, actually not the best particular follow-up for biochemical recurrence. However, with that being said, I also did a comparative analysis, specifically looking at the SEER Medicare data with over 120,000 patients and looking at brachytherapy versus cryotherapy, and actually found the converse with the use of secondary treatment modalities, i.e. the use of hormonal ablation, after cryotherapy versus hormonal therapy, and found that cryotherapy was inferior. But this is looking at the large kind of data, not specifically looking at PSAs and things of this nature, but more importantly, looking at the use from a global or a national perspective, the use of need for additional therapies such as hormonal ablation. And this also may kind of correspond, and as we put in our reply to author in the journal, it's the British Journal of Urology, and it's published, is basically suggesting that the knowledge of the utilization, it kind of goes back to the other question beforehand, when you're utilizing any kind of new technology, there isn't any, we're not, and during the time period that the study was conducted, 2004 to 2005, any well-defined criteria for defining when is what's the defined level for a biochemical recurrence. The data was still conflicting, and still is somewhat in regards to using Astro criteria, Phoenix criteria, and these are just variant criteria to define biochemical recurrence, as well as nadir PSA. Now that the data seems to be a little bit more solid, and it's still developing, in comparison to a lot of these other modalities of treatment that have extended follow-up, I think urologists that are utilizing, and the select few that are utilizing, I must say, cryotherapy are being a little less, how should I say, a little bit more, I think, comfortable with using the procedure. I'm trying to use the most PC word, but more importantly, have the knowledge to support them not doing a reflex and putting patients on hormonal ablation prior to actually needing it. I'm actually doing a study, and that's a great question that you bring up, with Dr. Ash over at St. Joseph Hospital. It's a retrospective study, but basically looking at our outcomes and comparing those to radiotherapy patients, and including the brachytherapy patients, which may be present, to see which patients, what's their biochemical disease-free survival at our own local institution, and comparing all the different treatment modalities. I would have to say, and I would have to probably agree what you're thinking, is there's even still an underutilization of brachytherapy, and as it pertains to prostate cancer. And I think there's even less now than there was before, particularly with the advent of robotics and surgery, which probably have taken a lot of patients that may have been treated with brachytherapy. And there's definitely less urologists, I know, that are conducting brachytherapy.
Thank you.
Okay, I'll go back to my last point that now we're going to break the formal part of the meeting, and Dr. Williams will stand behind Charles, who's monitoring our camera there, if you have any personal questions. But before I say good night, I would like to thank Dr. Marty Weissman, who is on our board of directors, and it's because of Marty that we were able to get Dr. Williams here and Enza to come in, because just so happens he's from St. Joseph's. So he was, he was able to arrange this meeting, and we thank you very much. We'd also like to thank Dr. Williams, and we'd like to give you about a $10,000 paycheck for your process tonight. Unfortunately, we're very limited with our money. So, you know, we've all heard that time is money. So we can't give you greenback cash right away, but we can give you some time. We're going to give you this Prostate Forum coffee cup, and it fits right in a glass holder of your car. So in your morning coffee, you don't have to sit at home and drink it. You can sit it in your car and drink it on the way to work, save you some time. Thank you very much, Dr. Williams. Here, I'll take your mic so you can't say anything more. Now you can go tear down your stuff, and I'll tear down my stuff, and then step behind Charles there. And any questions that you have personally, why he'll take care of you.